So in the last lecture we talked about the anatomy of the liver and the extrahepatic biliary system, and we also emphasized the importance that this understanding of anatomy has in operating on these patients, in understanding the conditions that these patients have, and how the functional anatomy of liver resulted in improvement in the treatment and management of those patients who have hepatic metastasis, especially along with colorectal carcinomas. The other important thing is to understand the imaging of this hepatobiliary and pancreatic area, and a very strong point of the armamentarium of these surgeons is to understand how different imaging modalities work and to use them and to understand what these imaging modalities are showing you, and that results in planning a better surgical outcome for your patients. So what are the different imaging modalities available? As we all know, the plain X-ray, ultrasound, CT scan, ERCP, PTC, MRCP and HIDA scan, all of these imaging modalities image the hepatobiliary pancreatic system. Now we'll one by one see what kind of imaging modalities to use and how to use them to the best advantage for our patient. So we will start off with the hepatic imaging. The most common tool used for imaging the hepatic area is, as we know, ultrasound. Why do we use ultrasound so frequently? 1, because it is non-invasive. 2, there is no ionizing radiation to be afraid of. 3, it is easily available. 4, it is much cheaper than any other imaging modality that we used commonly for hepatic imaging. Then what's the downfall? The downside is that it is a very operator dependent investigation, and a good or a bad ultrasound really depends upon the kind of operator who is using that ultrasound probe and the kind of machine that person has. Now, as we know, when we do an ultrasound, you must have seen a probe. The probe is the thing that you put on the patient's abdomen and then you get images on your machine. Now that probe has piezoelectric crystals, which when the electric current passes through them, they vibrate on a specific frequency which can be controlled, and that frequency of course cannot be heard by ourselves, and that is why it is known as an ultrasound. Now that probe then send these sound waves which pass through the organ, and then the reflection of that sound waves give the image that is displayed on the screen. Now it is a real-time investigation, and because it is real-time, the operator has to interpret whatever it shows. Now let's see what a normal liver looks like. If you see here, see, this is the probe. This is the area of the probe, and the area which is shown here is most distant from the probe, and this is the whole of the liver, and this is the capsule. This white line is the capsule, and you can see this is a normal liver with good homogeneous ecotexture, and you can see these various vessels which may be biliary channels or which may be channels containing blood. And if you look at this picture here, it is showing which are the vessels. The blue color denotes the venous blood and the red color denotes the arterial blood. Now this is the ultrasound of a normal liver texture, whereas if you look at this ultrasound and you compare it with the last one, you can see that this liver the parenchyma of this liver is not homogeneous anymore. ये एक जैसा नहीं है. अगर आपने पीछे देखा था, ये देखें कितना स्मूथ है. It is smooth, it is homogeneous. It's just like एक ही तरह के, एक ही साइज के, जैसे चावल के दाने या वो जो है ना, उनको आपने इकट्ठा किया हुआ किसी जगह. लेकिन जब आप यहाँ पे देखते हैं तो आपको लगता है कि ये सिर्फ कोई एक चीज़ नहीं है. There are different type of texture of different type of areas. And similarly, when you look here, look at the capsule, look at the line which is smooth, which does not have any breaks and which does not have alteration in its thickness. Whereas look at this capsule, it is different, it is not straight, it is curved at some side, it is thick and all. And then these black areas we'll talk about ahead also. This is actually the fluid which is surrounding the liver, the ascites which is formed. Then when you look at the liver and you find any lesion in it, anything which is not normal, you want to know about its size, the configuration, the homogeneity and the contour. And you can see there are various lesions now. In this liver we can see this is the probe, this is the capsule, this is the whole of the liver, these are the channels, and these are various lesions. Now these are white lesions, this is slightly darker, this is slightly darker margins, this has a darker area surrounded by different white patterns. Now what does this all mean? It can be explained here much better. Now when you have a lesion which looks bright as compared to the rest of the liver, this is called a hyperechoic lesion, because all ultrasound examinations that we see are echoes. So this echo is hyperechoic, it echoes more, the sound waves are reflected more from here. This one is a hypoechoic area, this is anechoic, which means it does not give any echo at all, and this is of mixed echogenicity. This lesion, this part of the liver gives echoes of different types in the same area. Now what does it all mean? A hyperechoic area actually means that this is reflecting the sound waves much more than the rest of the parenchyma, and it usually is when there is a fatty infiltration. When if you look at this, there is brightness in the parenchyma of the liver. Now this brightness is because of the liver infiltration, and this lesion also has its texture resembling fatty, the subcutaneous fat, and that is known as hyperechoic. Whereas when we talk about hypoechoic, it means it is not the same as the rest of the parenchyma, but has more solid sort of. When there is a solid lesion in liver, it gives a hypoechoic reflection. Whereas when there is fluid collection anywhere in the liver, it gives anechoic, which means there is no echo. And once there is mixed pattern, you can see how it looks like. So if you look behind, you can see these white areas, they actually reflect more fatty sort of texture, and this darker area is hypoechoic. It gives more, it tells you that it is more solid type of thing. Okay, and what about the intrahepatic channels? How do we know that they are intrahepatic biliary ducts or they are blood vessels? So you do a Doppler ultrasound along with the normal ultrasound, and as you can see here, these red areas, they tell you that this is arterial blood, and these blue areas tell you that this is venous blood. Then, as we already talked about, fatty infiltration, a very common cause of hepatic failure now is NASH, the non-alcoholic stereotactic hepatitis. Hepatic failures or hepatitis caused by fatty infiltration of the liver, and you can see how it has become brighter. There is a very poor definition of posterior aspect of liver. You can hardly find out where the capsule is, and there is impaired visualization of the borders of the hepatic vessels, which tells you that this liver has fatty infiltration. Then if you look at a fatty liver on a CT scan, as we all know, CT scan uses the same technique as a normal radiographic technique, but it is done with a computerized program, and the whole body is exposed to the radiation, or that part of the body you want to be examined. And once that is done, the computer program causes a 3D reconstruction, and then you can look at it. So if you look at this CT scan, you can see that there are areas of lower attenuation than normal portal vein IVC density, and there are hyperdense intrahepatic vessels. इनकी डेंसिटी बढ़ गई है और जो एटेन्यूएशन है जो नॉर्मल होती है उससे कम हो गई है. और अगर आप देखें, अगर आप नॉर्मल सीटी स्कैन के साथ इसको कंपेयर करेंगे तो आप देखेंगे कि इसका भी जो पैरेन्काइमा है इट इज़ ब्राइटर ऑल्सो ऑन द सीटी स्कैन. So, as we all know, hepatic cirrhosis is one of the commonest conditions that you would encounter in your medical professional career. So, what would it look like in an ultrasound? In an ultrasound, it would look like that there is surface irregularity, there is increased echogenicity, there is heterogeneous coarse ecotexture, and then there is ascites. This black is fluid. It is fluid along the liver. It is fluid along the liver. And there is, if this is the probe and this is the viscous, you can see this whole area is filled up of fluid, which is ascites. Similarly, another example of a cirrhotic liver, you can see the heterogeneous coarse ecotexture, the surface irregularity, ascites which is present, and decreased definition of the walls of the portal vein. You will see their borders are not distinct anymore as it was present in a normal texture of liver. So what does it tell us? What it tells us is that when the liver loses its ecotexture, when there is the coarse ecotexture, when the surface is irregular, when there is ascites present, and there is decrease in the definition of walls of the vessels, then the patient has a cirrhotic liver. Okay, what about the findings of cystic lesions? When you look at a cyst wall on ultrasound in liver, you see how the wall is very, very thin. The wall is thin, but it is well defined. The borders are well defined. It is a thin wall, well defined structure, and it is anechoic. It is black. You can see it is black, and there is distal posterior enhancement. यहाँ पे काला है और यहाँ पे आप देखते हैं सडनली ब्राइटनेस आ जाती है. ये पोस्टीरियर एनहांसमेंट है. डिस्टल का मतलब है ये प्रोब है, इट इज डिस्टल टू द प्रोब. सो इट इज वेल डिफाइंड, it is anechoic, and there is distal posterior enhancement. So it tells us that it is a cyst, and you can see a liver may have multiple cysts lying in the liver, and you can also see how it looks like on a CT scan. On a CT scan also you can see that the density is much less than the rest of the density of the liver, and the border is thin, it is well defined, the density is less. Similarly here, well defined border, anechoic, distal posterior enhancement. And we know polycystic liver condition, it's a congenital condition. Some people are born with it, with having polycystic liver or renal, and these patients subsequently end up having hepatic failure and would require hepatic transplants. So now what about a hepatic abscess? That was about a simple cyst. But once there is an hepatic abscess, the abscess can be an amoebic liver abscess or it can be a pyogenic abscess. In an hepatic abscess, as you can see here, there is a hypoechoic rounded lesion which also has well defined mildly echogenic rim. See the rim of this structure, the rim of this lesion is well defined and it is echogenic, brighter in color, and then you can see that the density of the echo density of this lesion is varied. It means it has different type of echoes coming from the same lesion, and then you can see clumpy debris and low level echoes and sometimes you can even see a fluid debris level. And then once you make the patient move, there would be echogenic reflections with reverberations. तो जब पेशेंट को आप हिलाते हैं, अल्ट्रासाउंड का प्रोब रखते हैं और पेशेंट के पेट को हिलाते हैं, तो ये एब्सेस हिलती है और इसके अंदर जो डेब्री होती है वो भी हिलती है. एंड यू कैन आइडेंटिफाई दैट ऑन अल्ट्रासाउंड बिकॉज इट इज़ अ रियल टाइम इन्वेस्टिगेशंस. Once again, it is an abscess. Look, it is hypoechoic, which means slightly solider than the rest of the liver parenchyma. It is well defined. The margin is mildly echogenic. It is stronger than the rest of the lesion. Then there are coarse clumpy debris, low level echoes, and you can see debris fluid levels. And once the patient is moved, you can see it's the same lesion and the patient is moving here, and you can see the echogenic reflections with reverberations. बिल्कुल बाकायदा हिलते हुए नज़र आते हैं आपको जो डेब्री होती है उस एब्सेस के अंदर. Similarly, if you look at a hepatic abscess on a CT, what would you see? As shown in these images, you can see it is once again well defined, and the density is less than the rest of the density of the liver. And in some features of sometimes you can see an air fluid level or a level between the fluid collected and the debris present in the abscess, which is not present in this image that we are seeing. Now, how to differentiate a hepatocellular carcinoma from the abscess? Now, once again, remember this thing: whenever you diagnose a patient, you diagnose it on history, physical examination, and investigations. The diagnostic pillar to rest on is the physical examination, history of the patient. The investigations aid in the diagnosis. So this patient who probably has a hepatocellular carcinoma, on first look you would feel like this is just like a hepatic abscess that you saw, but it is different. Look at this. Look at this. What is having? This is also having mixed echogenicity, but the rims are not echogenic. The border is not well defined. There is some clumpy debris here as well, because there is there is necrosis in this, and this kind of necrosis is not liquefactive, and that is why this is more debrigenous. Now, about 60% of the hepatocellular carcinomas present with this kind of picture on an ultrasound, whereas a hypoechoic, remember what did we say? What is a hypoechoic lesion? A hypoechoic lesion in liver means, which is, or an ultrasound means, which is more solid than the rest of the parenchyma. So it is a solid lesion present right here, and 25, about a quarter of the hepatocellular carcinomas have this kind of solid lesions, but more about 60% have what is mixed echogenicity, both solid and liquid, and 26% solid, and then about 13% of them have this kind of hyperechoic. Remember what we talked about? Hyperechoic is when it resembles the subcutaneous fat. The density of this kind of lesion resembles the density of fat. Now, this is because of some fatty metamorphosis or marked dilatation of the sinusoids. Then the most important diagnostic modality for a hepatocellular carcinoma is a biphasic contrast enhanced CT scan. Biphasic, which means there would be two phases. There would be an arterial phase and there would be a portal venous phase, and sometimes we do a triphasic in which there is an arterial phase, a portal venous phase, and a venous washout phase. And that is sometimes if you have to differentiate between a hemangioma and a malignancy. But right now we are talking about a hepatocellular carcinoma, and the best modality to investigate a a hepatocellular carcinoma, to image a hepatocellular carcinoma, is a biphasic contrast enhanced CT scan, and you can see that this lesion has an enhancement during hepatic arterial phase. This is the lesion, and this is the contrast present in this lesion during the hepatic arterial phase. And as we already talked about, that the hepatocellular carcinomas, the malignancies in the liver, have arterial supply. Most of the times the arterial supply is the main blood supply of the hepatic malignancies. And once you do a biphasic contrast enhanced, you can see the enhancement during arterial phase. The contrast is going inside the tumor, and you can see the lesion is here and it is being enhanced, and it is a mixed, if we would have done the ultrasound, there would have been mixed echogenicity, because there is non-liquefactive necrosis also in this liver. And where is it present? Anatomically it is present in the right lobe of the liver. And what happens once there is portal venous phase? In portal venous phase there is decreased attenuation, which means that the arterial phase is enhancement बढ़ जाता है, क्योंकि जो आर्टरी है वो सप्लाई कर रही है उस ट्यूमर को, तो उसकी वजह से जब आप कंट्रास्ट आर्टरी के ज़रिए जाता है तो वो बढ़ जाता है. पोर्टल फीनस फेज में जब हम लिवर को देखते हैं तो जो होनी चाहिए कंट्रास्ट की एक्यूमुलेशन की, जो डिक्रीज्ड, जिसे कहते हैं डिलेड वॉश आउट होता है, देर से निकलता है कंट्रास्ट. अगर आप देखें तो जो रेस्ट ऑफ द लिवर है उसमें से जल्दी चला गया कंट्रास्ट, लेकिन यहाँ से देर से जा रहा है. और जो पोर्टल वीनस फेज के अंदर हम देख सकते हैं कि ये इनहोमोजेनस है. हमें आर्टीरियल फेज में इतना साफ नहीं नज़र आया था, मगर पोर्टल वीनस फेज में हमें नज़र आ रहा है कि ये जो लीजन है ये इनहोमोजेनस है, इसका एक जैसा टेक्सचर नहीं है. इसका मतलब वेरिएबल टेक्सचर है, कहीं पे ये सॉलिड है, कहीं पे, विच टेल्स यू दैट देयर इज नेक्रोसिस गोइंग ऑन इन दिस ट्यूमर. देन इन डिलेड फेज, जब डिले कर देते हैं पोर्टल वीनस फेज के बाद जो वीनस वॉश आउट फेज होती है, तो उसमें आप देखते हैं कि ये आइसोडेंस है. ठीक है, बाकी सारे लिवर को देखें, बाकी सारा लिवर कैसा है और उस मुकाबले में ये लीजन कैसी, ये आइसोडेंस है. दिस इज आइसोडेंस. सो इस सारे को जानने का हमें फ़ायदा क्या, हमने इमेजिंग कर ली, हमें आइडेंटिफाई हो गया. ये देख करेक्टरिस्टिक है कि ये हेपेटोसेलुलर कार्सिनोमा है, और ट्रेडिशनली सॉलिड ऑर्गन ट्यूमर्स में हम नीडल बायोप्सीज को अवॉइड करते हैं, लिवर के अंदर करते हैं ताकि वो ब्लीडिंग वगैरह ना हो. और ये सीटी स्कैन तकरीबन डायग्नोस्टिक है ऑफ दिस काइंड ऑफ लीजन. और इसको हम इस्तेमाल कैसे करते हैं ट्रीटमेंट के लिए, अभी इसके बारे में भी हम बात करेंगे. अल्ट्रासाउंड पे हम क्या देखते हैं, अल्ट्रासाउंड पे देखते हैं कि वास्कुलर सप्लाई कैसी है. हमें पता है कि मोर कॉमन वास्कुलर सप्लाई क्या है ट्यूमर की, दैट इज़ हेपेटिक आर्टरी. But in 6% of cases, portal vein can also be the main supply of hepatocellular carcinoma. Then, using this very interesting anatomical fact that the hepatocellular carcinoma is fed by an hepatic artery and not the portal vein, we use that and do a transarterial chemoembolization TACE. So we pass a catheter into the hepatic artery, and through that catheter we chemoembolize. That would decrease the blood supply of the tumor, it would shrink the tumor, it would downstage the tumor, and it would make a tumor which was perhaps not resectable before doing TACE, then after TACE it may become resectable. And as you can see, after second TACE the size of the lesion has decreased definitely. And in the previous one you could see it was occupying nearly the whole of the right functional lobe, and in this the size has decreased, and then a surgeon might think about now resecting this tumor. This is transcatheter arterial chemoembolization. Now, what is the most common malignancy of the liver? The most common malignancy of the liver is a metastasis, and this is how metastasis look like on an ultrasound. Look on these multiple lesions present in the hepatic parenchyma Look at the poor borders these have, and the liver's ecotexture is gone. Nearly the whole of the liver is replaced by metastasis. Now this brings us to biliary imaging. Right now we have done the solid organ imaging. Now biliary imaging, we know the extrahepatic, the intrahepatic biliary channels, they are low pressure systems, and we know the anatomy that the right and the left hepatic ducts form at the confluence, which is at the porta hepatis. Then common hepatic duct is formed, and when the cystic duct joins the common hepatic duct, it forms the common bile duct. The common bile duct has a supraduodenal, a retroduodenal, and an intraduodenal region. Now how do we do imaging of the biliary system? The most important, once again, imaging system that we use is the ultrasound. And ultrasound, why do we use ultrasound? As we've already talked about before, it is non-invasive, it has no ionizing radiation, it is easily available, and it is cheap to do. But once again, the downside is that it is operator dependent. So once we do talk about the ultrasound of the gallbladder and the biliary system, the normal size of the gallbladder is about 7 to 9 centimeter. This is the gallbladder here. The width is 3 to 4 centimeter. The wall thickness, it is a very important thing, the wall thickness. The normal wall thickness of gallbladder is 2 to 3 millimeter. The normal size of bile ducts, the right and left intrahepatic ducts just proximal to the porta is 2 to 3 millimeter. The proximal common hepatic duct and the common bile duct is less than 8 millimeter. Once the size of the common bile duct or common hepatic duct is 8 millimeter or more, we say it is dilated. Now the ultrasound is 95% sensitive for gallstones, and it is more than 90% sensitive for acute cholecystitis. And you can also elicit a sonographic Murphy sign, which is when you press on an inflamed gallbladder. Because of the pain, the patient arrests his or her breath. But this is the very important thing, that it is limited by the skill of the operator and patient's body habitus. बहुत ज़्यादा मोटे लोगों में अल्ट्रासाउंड से इमेजिंग को करना ज़रा दुश्वार है. नॉर्मल गॉल ब्लैडर ऐसा नज़र आता है. हमने अभी बात की थी कि नॉर्मल गॉल ब्लैडर का साइज़ 7 to 9 सेंटीमीटर होती है लेंथ, उसकी वेट 3 to 4 सेंटीमीटर होती है, और वॉल की थिकनेस जो है 2 से 3 मिलीमीटर या उससे कम होती है. एंड यू कैन सी इट इज़ फिल्ड विद फ्लूइड, एंड दैट इज़ वाई इट इज़ anechoic, and there is no other structure visible inside the lumen. Whereas in this gallbladder, if you see, this is the gallbladder, and these are structures which are hyperechoic. And if you see, there is this long acoustic shadows, all of them. जैसे कहते हैं ना कि बुराइयों के लंबे साए होते हैं, इसी तरह ये जो गॉल ब्लैडर के अंदर ये स्टोन्स हैं, इनके भी लंबे लंबे साए हैं, acoustic shadows है. So they are hyperechoic with acoustic shadows, and this is the gallbladder, this is the liver, and you can see the capsule of the liver here. What about if the gallbladder does not have a definite stone but has sludge? If you look at the I hope you can see that the density of this part of the gallbladder's lumen and this part is different, and it looks like here the fluid is more thicker because it is resembling the aquatexture of the surrounding parenchyma as compared to this part which is totally black. Another investigations which is done nowadays is a HIDA scan, a scintigraphy, in which radium dye is given and it is excreted through the biliary channels, and it is now done to see the whether or not the gallbladder is functioning. It is an investigation which is done to see acute cholecystitis. The gallbladder is not functioning, and also it also tells us about the excretion of the contrast, and whether or not, if it is difficult to otherwise localize whether there is leakage of the bile, sometimes this HIDA scan can be used, the scintigraphy can be used. Plain X-ray of the abdomen is not a very reliable investigation, especially for biliary system. Only about 7% of the gallstones are radiopaque on plain X-ray, so that is why you used another technique like oral cholecystogram was used before the advent of ultrasound. And हमारे जो सीनियर्स थे जिस ज़माने में अल्ट्रासाउंड अभी easily available नहीं था, oral cholecystogram was the investigation of choice to identify gallstone disease. Sometimes however, जैसे हमने कहा 7% लोगों में हो सकता है, तो you can see the plain X-ray showing these stones, a plain X-ray showing these stones. Then somebody can ask you कि plain X-ray में जो stone नज़र आ रहे हैं ये right kidney में क्यों नहीं है? How do you know ये gallbladder में है? So ideally you should also get a lateral view, and the stone in the kidney would be posterior to the vertebral body, and the stones in the gallbladder would be anterior to the vertebral body. And sometimes on plain X-ray you can also see a porcelain gallbladder, which is actually a gallbladder which has a calcified wall, and it is considered to be a pre-malignant condition. The oral cholecystography is not done anymore, it is not required, and it consisted of giving your patient orally a contrast material which would be accumulated and then excreted in the biliary channels, and if there were any stones in the gallbladder it would appear as filling defects. You would take a control X-ray one day before, and then you would give the oral contrast, which is known as biloptine or telepaque tablets. 6 tablets were given, and then the patient was, another film was taken, और उसके बाद पेशेंट को एक फैटी मील देते थे. आमतौर पे हलवा पूरी मंगाई जाती थी, मरीज़ एक पूरी खाता था, बाकी सारे डॉक्टर मिलके खाते थे हलवा पूरी, और फिर उसके बाद दोबारा 1 घंटे के बाद ये देखने के लिए कि गॉल ब्लैडर फंक्शन कर रहा है कि नहीं, कॉन्ट्रैक्ट किया है कि नहीं, फिर एक दोबारा फिल्म ली जाती थी. नाउ दिस इन्वेस्टिगेशन इज़ नो मोर रिक्वायर्ड, इट इज़ नॉट डन, इट इज़ जस्ट टू गिव यू सम हिस्टोरिकल पर्सपेक्टिव, या कोई मेरे जैसा जो है वो आपसे पूछ भी सकता है. Then this was about regarding the gallbladder, but if you want to look at the biliary channels, what are the various modalities available? This one, the percutaneous transhepatic cholangiogram, is done for proximal biliary channels. Proximal जैसे हमने पिछले लेक्चर में एनाटमी में बात की थी कि जो सिस्टिक डक्ट की इंसर्शन से पहले जो है हम उसको प्रॉक्सिमल कहते हैं, और कुछ लोग इसमें सुप्राडूनल पोर्शन को भी ऐड करते हैं. प्रॉक्सिमल बिलरी चैनल्स को देखने के लिए पीटीसी इज़ अ गुड इन्वेस्टिगेशन, मगर इसमें इट इज़ मोर इन्वेसिव. द नीडल हैज़ टू गो थ्रू द लिवर पैरेन्काइमा, देयर इज़ अ वेरी हाई लाइकलीहुड दैट यू कैन इंजर अ वेसल, द पेशेंट कैन ब्लीड. और जब शुरू में किया जाता था तो सर्जन तैयार होता था, थिएटर तैयार होता था, 4 पॉइंट ब्लड तैयार होता था, फिर ये पीटीसी करते थे. अब अल्ट्रासाउंड और वो बहुत ज़्यादा चूँकि इम्प्रूव हो गया, एंड यू कैन आइडेंटिफाई कि जो आपकी नीडल है वो बिलरी चैनल में जाएगी, इट वुड नॉट हिट अ ब्लड वेसल. सो नाउ दिस इज़ डन अंडर अल्ट्रासाउंड कंट्रोल, एंड यू कैन सी अ नीडल इज़ पास. जब वो नीडल चली जाती है फिर उसके ऊपर गाइड वायर, और फिर उस पर से एक कैथेटर डाल देते हैं, और इस कैथेटर से आप कंट्रास्ट दे के इमेज खींच सकते हैं. इसके ज़रिए आप स्टेंट पास कर सकते हैं, इसके ज़रिए इवन स्टोन्स भी निकाल सकते हैं, एज यू कैन सी हेयर. दिस PTC, percutaneous transhepatic cholangiogram, is showing that the bile ducts are dilated. This is the catheter which has gone through, and this PTC, as you can see, the catheter is coming from the lateral side, has shown that there is a filling defect. Remember, a normal gallstone is usually not visible on a radiograph. It would appear as a filling defect on a contrast given like here. और ये क्या चीज़ें पड़ी हुई हैं, ये क्या है, what is this? Yes, you are right, these are clips. ये इस पेशेंट की लेप्रोस्कोपिक कोलिसिस्टेक्टमी हुई है perhaps, और ये एक स्टोन है जो कि CBD में था, जो परहैप्स पहले मिस हुआ, आइडेंटिफाई नहीं हो सका फॉर वट एवर रीज़न. Now they have found out that the cause of obstructive jaundice in this patient would be this stone in the common bile duct. अब क्या किया होगा उन्होंने? What can they do? They have removed the stone through a basket. यहीं से उन्होंने ये गाइड वायर डाली, ये कैथेटर है, इसमें से गाइड वायर नज़र आ रही है. इस गाइड वायर से उन्होंने एक डॉर्मिया बास्केट डाल के उस स्टोन को यहाँ से निकाल लिया बाहर. So it can be done like this. Even stents can be placed through a PTC, or you can do PTBD, percutaneous transhepatic biliary drainage, in which you provide external biliary drainage. Then you can do an endoscopic retrograde cholangiopancreatography, which is known as an ERCP. ERCP is done for distal biliary channels as well as for pancreatic channels also as well. It has it causes less discomfort. It is comparatively less invasive than a PTC because you do not go through the liver. You put in a scope, which is a endoscope through the mouth inside the duodenum, which is a side viewing scope, and as you can see, it's not an end viewing, it's a side viewing. Identify the ampulla. After identification of the ampulla, you place this catheter, and with this catheter you can inject the contrast, you can take images, you can take brushings, you can take cytology, you can take a biopsy, you can place a stent, you can remove stones through it. So it is both PTC and ERCP are both diagnostic as well as therapeutic. Whereas PTC के अंदर इम्कान हो सकता है लिवर के अंदर ब्लीडिंग का, ERCP का काफ़ी हाई चांस है कि ये पेनक्रियाटाइटिस कर दे, क्योंकि आप ये देख रहे हैं जब ये एम्पुला से जाएगा कॉमन पाथवे से, तो इट कैन ब्लॉक द पेनक्रियाटिक डक्ट एंड रिजल्टिंग पेनक्रियाटाइटिस. The most important indication once again is, as we know, is obstructive jaundice, and this is how it looks. When you place an endoscope, there is this minor papilla where is the accessory duct of pancreas is opening, and there is this major papilla through which both the biliary pancreatic ducts are opening inside the duodenum. Now with a side viewing duodenoscope, you cannulate it, and after cannulating it, you give contrast for imaging, or you perform a procedure, you remove the stone, you place a stent, or you can take a biopsy. Now as you can see in this is the endoscope, this is the image of an ERCP, and this is the CBD, and it is full of stones. As I've already told you, these appear as filling defects. These are filling defects of the contrast. Or you can see here that not only the common bile duct but also the pancreatic duct is visualized, and you can see the side viewing, you can see the guide wire going inside the ampulla and causing that, and there is this filling defect, a small stone there. So the size of the CBD is common bile duct is dilated, whereas the pancreatic duct is normal. Now this patient has a very high chance of developing pancreatitis subsequent to this procedure. Once again you can see a filling defect here, a stone left. Then MRCP, this is the magnetic resonance cholangiopancreatography. It is more available now than it was before. Why is it used? It is used when you are only using it for diagnosis. Of course it cannot give any therapeutic benefit, it cannot remove a stone, it cannot put in a drain, it cannot give you a biopsy, but it gives you good mapping of the area. It is replacing PTC and ERCP, but only for diagnostic purposes, and this is how it looks like. The benefits are कि MR के जो benefits हैं, as we know, there is no ionizing radiation. The patient does not have to withdraw any kind of invasion, but of course इसकी limitation once again ये है कि आप इससे कोई therapeutic काम नहीं कर सकेंगे. As you can see, इस patient का ये gallbladder है, CBD, and the pancreatic duct is visualized. CBD is slightly dilated, and there is the common junction of the CBD and pancreatic duct. This MRCP is showing multiple stones in the common bile duct. Now just a very brief overview of pancreatic imaging. We'll talk about pancreatic imaging in detail when we are talking about the pancreas in full. As we know, anatomically it is located in the stomach bed. It is a retroperitoneal organ. The head is adjacent to the duodenum. The tail is extending towards the spleen, and the splenic vein and arteries posterior to the body and the tail. The portal vein confluence is immediately posterior to the neck of the pancreas, and that is the boundary where you divide the pancreas when you do a proximal pancreaticoduodenectomy. A most common, most valuable, most useful investigation for acute pancreatitis is a contrast enhanced CT scan. Both oral and IV contrast are given. Now, when do we do a contrast enhanced CT? When the clinical diagnosis is not clear, when the Ranson score or the Apache score is showing that your patient has moderate pancreatitis, or the patient is not improving with medical therapy, or if the patient improved initially but now is not doing well. What can you find out? You can find out peripancreatic inflammation, any edema, fluid collections, necrosis, or thickness of the perineal fat. Now you can see here in this patient, you can even see a gallstone which is stuck here, and you can see the whole of the pancreas is swollen. Whole of the pancreas is swollen, and the white arrows are showing the peripancreatic inflammatory changes, which is actually fluid here. And look at this. The whole body and tail has been replaced by this fluid collection, and only viable pancreatic tissue is perhaps here, left here. The rest of the gland has been destroyed by inflammation. Now you can also do a CT scan with gallium. It can localize infection, and you can see there is this necrosis going on, and this patient may require dealing with this necrosis, maybe even with interventional radiology. Or a CT scan can tell us about a pseudocyst of the pancreas, which forms in about 10% of the cases, and it only is significant if it does not resolve spontaneously. It usually resolves in 4 to 6 weeks time, and it is seen within the pancreas itself or the potential spaces which are all around the pancreas. And the most common site is in the lesser sac, as you can see here, and that is why this is the inflammatory area. This is the spleen, and there are some areas of higher attenuation which tell that there has been some bleeding inside. Now pancreatitis can cause erosion of the vessels which are surrounding it, and can cause serious bleeding resulting in hemorrhagic pancreatitis, which is a very, very high mortality. Similarly, there is this fluid collection in the lesser sac. This is the stomach, in the stomach bed, and this fluid, this is blood. It tells you that there is some bleeding inside, and you may have to do something to stop this thing. When there is air inside the parenchyma and signs of inflammation, it tells you that this inflamed organ is now infected as well, and these patients would require what is known as necrosectomy, which once again has very high morbidity and mortality. So we'll stop our talk here. I hope it has been useful. Please give us feedback about the talk that we have just heard. How can we improve this online? What other things we can add to this presentation which can improve your understanding? Thank you very much.